I personally also prefer this boost bleach in office and do home bleaching. And I have one question that I sometimes find it a little bit difficult to really foresee and also give a good guidance to our patients. What do you say to your patients when they can see the first effects? If they just do home bleaching without any in-office boost? Because the expectations are high.
Obviously, a lot because of the dehydration, right? The at-home bleaching, I would say that as a standard, if I have a patient that has never bleached before, a home bleaching technique using 1 to 2 hours per day with a 10% carbamide peroxide is a procedure that will take around 3 weeks, 4 weeks to finish. But he will be able to see result. What's the earlier, of course, but what's the problem with the at-home bleaching for the patients to see results? Because the patients looks at the mirror 3 times a day. If I'm bleaching 21 days times 3, it's 63 steps that he would watch on the mirror. And of course, if I divide in such subtle steps, he won't see that much. So it's something very common for the patient when he arrives after 10 days, 2 weeks to do this, I would say, a checkup consultation and see how everything is going. The patient says, I'm not seeing that it's bleaching that much. So I usually ask, do you remember what was our original color, our baseline color? So yes, it was A3. I always show to my patient, it was A3.5. And then I pick that shade tab and I place in front of the tooth, and it's much whiter, of course, at that moment. And then the patient actually believes that it's working, and he starts to, I would say, to give value to the treatment. But that's a very nice concern. And that is actually one of the, I would say, psychological reasons that support the combining technique. Because you have this jump start, and it sees the result. You don't need to tell them with that much, that's almost everything dehydration, just one session, but it is. But yes, this is for sure something that in the at-home bleaching, you need to explain that you won't see very striking changes in a very fast time.
And usually, how do you plan your follow-up visits if they do like a guided home bleaching? How often you ask them to show up? Like every 10 days?
Usually we ask in 2 weeks here. In 2 weeks, I see them again. And nowadays, it's becoming easier also to communicate with the patients because of WhatsApp and everything. So write a patient a message. How is it going? Are you seeing no sensitivity? And it's very nice. The patient seems that you're paying attention in the case. And sometimes we can't. Is he using the at-home bleaching adequately? Sometimes, I had a trip and I forgot the bleaching agent, so for 4 days I'm not using. Okay, so maybe we need to postpone our consultation. But usually 2 weeks, and then a final consultation for the end of the treatment. Usually it's baseline and treatment 14 days and 21 or 28 days according to the desire of the patient. But if I see that for like a whole week it's not having any effect, it's not getting any lighter, probably already reached the saturation point of that bleaching regimen, and it won't bleach much more than that. It's a biological treatment, so we cannot say exactly at the beginning how much is gonna get lighter or whiter.
Yeah, I think we can discuss bleaching forever, and probably there are more questions. I think we should give this an extra topic, like extra event. But certainly, since I know that you have prepared more interesting cases for us, I think we should proceed with something that I really looking forward to your presentation regarding aesthetic improvements of white enamel opacities using infiltration.
Perfect. Let's go on then with the not with darkened teeth, but with teeth in which the problem my patient has is it's too white. I have white spot lesions because of caries lesions around brackets. I have white or diffuse opacities because of fluorosis here and here, for example. I have fluorosis and molar incisors hypomineralization. And this is something that has everything to do with the resin infiltration procedure. That is something that DMG brought to the market some 10, 11 years ago. And resin infiltration was first actually invented, I would say, for controlling proximal carious lesions. It had lots of evidence on how well it works. So, but for white spot lesions or enamel opacities, how does it work? And this is something that we need to understand the process so we can actually indicate the best way of treating it. So if I have these white spot lesions, usually what do I have? I have microporosities in the enamel subsurface. I usually have an enamel layer that is intact, it is very well mineralized, but in the subsurface, I have a region which I have demineralization in caries cases or an hypomineralization in fluorosis or MIH cases. And those microporosities that they are filled either with water or with air, and both water and air, they have a very much lower refractive index than a natural enamel, and that's why we see this whitish appearance on those lesions. We can think, for example, on those caries lesions on many possible treatments. For example, just let remineralize, and remineralization works in controlling, of course, the lesion progression, in reducing the optical appearance of those lesions, but only in very superficial lesions, okay? Because remination occurs, please pay attention here at the scheme here, only more superficially. And you have still those areas that are filled with water or air in the subsurface. So only remineralization, sometimes they do not achieve the perfect aesthetical outcome that some patients require. I can think about bleaching, yes, because if I bleach the tooth structure and reduce the contrast between the white spot lesions and the tooth, probably this is going to happen. It's going to get a little bit more lighter, the difference of color. It will reduce. But usually I wouldn't say that bleaching a whole mouth only for that indication of reducing the contrast would be a very nice protocol. In spite of many times we're joining the bleaching procedure when we're treating those kind of patients. Microabrasion is a very known technique. And in microabrasion, I get this mixture of an abrasive and an acid, and I microabrade the surface, removing the superficial enamel, affected enamel, until I achieve a subsurface enamel that is, I would say, with a normal color. What is the problem of microabrasion? My result depends on removing affected enamel, and that might not be that micro-invasive. We lose this superficial enamel, and we lose around, depends of course on the pressure and how many times you repeat it, but some studies they say around 200 micrometers, zero 0.2 millimeter. And if I think on a cervical area, come on, that's almost half of the enamel I have. So sometimes it's not that minimally invasive as we would like. And we have some in vitro data that shows the difference of microabrasion with other, I would say, more micro-invasive approaches. Sometimes the only way we have to answer to the patient's demands, statical demands, is by removing the lesion and placing a restoration. But I don't think that we can say that this is the ideal situation. It's just for cases and it doesn't work in any other way that is less invasive. And then comes resin infiltration. In the resin infiltration technique, what is the idea? First, we place an acid, an hydrochloric acid, that will remove a little bit of the enamel surface, the corrode, a little bit of the enamel surface, around 30 to 40 micrometers. So much less than a micro abrasion approach. And with this, we're gonna have some permeability of this surface, accessing the subsurface layer where I have the microporosities. So after action and rinsing and drying, we apply an alcohol. The alcohol dehydrates that enamel. We go with some air to make it very, very dry. And then we place a very low viscosity resin. And this low viscosity resin, you can look here in my hands, it goes and by capillary attraction, and it goes and goes and goes and starts filling all those voids, all those micropores, all those spaces inside the lesion. And then we light cure. Once we light cure, those spaces that were filled with air or water, now they're filled with resin. And this resin, after light cured, this resin has a refractive index of 1.54, 1.53, much closer to the 1.62 of the enamel. And then what happens? You almost don't see those whitish areas anymore. Okay, so in a carious white spot lesion, what happens? We have, for example, here the lesion, subsurface lesion, a very thin layer of surface enamel. We apply first the acid in letter B. We leave it there for around 2-3 minutes. Then we rinse, we dry, we apply the alcohol, we over dry this region, we infiltrate, we light cure, and then the lesion becomes almost invisible. This is one of the first cases I performed. That's like 10, 11 years ago. Today we learned a little bit more, the system evolved a little bit more, but I want to show my first experience with Icon. So with Icon, with resin infiltration. So we had the baseline here after I placed rubber dam and the acid, and here's the immediate result. Like 15 minutes after I infiltrated, you have here the lesions almost invisible. That in a clinical situation, it won't be a static problem anymore. Here, some cases that you have the white spot lesions around braces, and the immediate result. So for carious white spot lesions is a very nice alternative. Of course, will it be a perfect result in all cases? No, it depends on how much it can infiltrate the lesion. If you have very, very severe cases with very deep areas of demineralization, as we had in this case here, look how opaque and sometimes already cavitated lesions here that need to be restored. Here, only resin infiltration won't do the trick. Okay, we can do resin infiltration step by step, acid, drying, applying the infiltrant, as you can see here, light curing. And this here is the immediate result. Did it become much, much better in just one session? Yes, it did. The patient now is much more motivated to make better oral hygiene and take care, what she wasn't doing very well during orthodontics. But you can see that some areas it's not perfect. So please also understand the limitations of the material and the correct indications for it. For those white spot lesions, we have lots of science on that. It was the first, I would say, official indication for smooth surfaces and with very nice results, very nice results. Many journals, many papers already place resin infiltration technique as something that is between like the preventive measures that sometimes didn't work that well, but come before you go and restore or destroy enamel on those cases. So please be aware of this possibility. One area in that we have some expertise here in Brasilia is on treating resin infiltration and fluorosis cases and mild and moderate fluorosis. So the same idea applies. I have subsurface areas of hypomineralization. So I need to break a little bit of this surface enamel here to have access to the subsurface hypomineralized enamel. So what we do the acid, as you already know, we dry, and we drop a little bit of the alcohol, of the Icon dry, that is to dry up the lesion. Then I look. If I see that the alcohol changed the optical appearance of that while it didn't evaporate, I go further. If I see that just one acid etch didn't get me access to the subsurface lesion, I can repeat the acid one more time or two more times to try to achieve a little bit more access for my infiltrant into the subsurface area of hypomineralized enamel. And then I do the infiltration, then I light cure, and usually the results are nice. An example, this patient here, she complained about the diffuse white opacities, a characteristic of this, I would say, mild to moderate fluorosis. So we did the acid etch one time. I left for 2 minutes. Then I suctioned the acid, rinsed, and then I placed a little bit of alcohol, the icon dry. As I dropped a little bit of alcohol there, I looked and saw, I still seeing a lot of whitish bands. So my alcohol didn't get access yet to the subsurface. I need to etch once more. I did that. I did that consciously, that I'm removing a little bit more of enamel, but I need to answer to my patient's aesthetic demands. And then I drop the alcohol once again. And after 2 etchings, you can see the difference. One etching, I'm seeing here whitish bands below. Here, I'm seeing much less. So now I can go further and apply the infiltrant and wait for the infiltrant by capillary attraction to infiltrate the lesion, and then light cure and do the polishing, the finishing and polishing of these surfaces with soft like discs, with rubber wheels, or whatever you use for polishing. Okay, and here you have the immediate final result. So we don't see these diffuse opacities anymore. The patient was very pleased. You can see it's a very natural result. And here you can see like part of the screen how it was, and part of the screen how it almost disappeared, those whitish opacities that we have because of fluorosis. And she was very happy also with the final smile, with a very natural final smile. This patient, she's a dentist, so she was very pleased with the result, with this micro-invasive technique to solve her problem. What was the problem? The whitish opacities of fluorosis. We have here a very nice paper from the team of our dear friend, Dr. Michael Wicht from the University of Cologne in Germany, where they associated first bleaching and then resin infiltration for masking fluoritic opacities, and they had fantastic results with this combination. And this is something that we also doing here. Usually, if I have a patient, young patient, and he wants to treat fluorosis, we first bleach. Teeth become extra white with the association of bleaching and the fluorosis. But then after, when we resin infiltrate the fluorotic lesions, it has a very nice effect. White teeth because of the prior bleaching, and with no opacities, with a natural translucency of the enamel as a result. So I really enjoy associating those techniques. This is another patient where we use rubber dam and not the liquid dam, as you have seen. In patients where I have fluorotic lesions up to the cervical third, using a rubber dam and retracting a little bit of the gingiva is a very nice tip I like, and today is the way I do most of my cases with rubber dam. Okay, so you have here a case of moderate fluorosis, and then it's the same idea. I icon etch, and then I remove it, I rinse, I dry. Sometimes I need to repeat the etching step, as I explained to you. You see how much better it looks after I drop a little bit of alcohol after one etch or 2 etches, and then I perform the infiltration, and you can see this fantastic immediate result in the same session for this patient here. It was like a child that was suffering for bullying at school because of the white teeth. So the parents brought the child to our dental clinic university, and we could here find a very micro-invasive approach to deal with the clinical problem. So very nice and natural smile after the resin infiltration. This is one of my first cases with a patient, also a dentist. He was a dental student at the time. Look at the fluorosis, the same idea. But here I did just one side So I could see the difference in the same session. Of course, I did the other side later on. So you can see here that I etched twice, as I explained you, uh, with the alcohol, with the icon dry, showing the optical difference after infiltration and after polishing that side. So you have in the same patient how it was because it was untouched, and how and after treatment here in the other side in the same sessions, like 30 minutes from the initial image to this one here. And you can see the huge change that we had in the statics of this patient here. So here will be our before, and here our after in the same picture. Of course, then we did the right side, and this is the immediate image after the treatment. So before and after, before and a close up, and after. And the question that many people place, and how is in the long term, does it stains? Does it gets worse? Does it get better? I can show you this patient here, a picture of 5 years later. So this is 5 years after the procedure. You can see no staining, no problem. The patient is very happy. And now I'm trying to get in contact with him, so he comes back to our clinic so we can take the pictures now of 7 years after the procedure. That's the time already this case has. So I'm very pleased with this case. It's one that I like a lot because also of the long-term follow-up that we have with very nice results. So for fluorosis, we have systematic reviews that tell us that resin infiltration should be maybe our first option for those cases, and then microabrasion, not the opposite way around as it was some years ago, because it's less invasive and has nice results. This fresh study here, it was published, I think, 2 or 3 days ago, shows also in a systematic review that resin filtration has a very nice capacity of masking effect, much more than remineralization or just fluorides, as I explained you some slides earlier. We have a study in which we evaluated the available literature, not only on the masking effect, but also in the stability that the color has with time. And we were seeing some very nice results. This paper, we're ending the writing of it, and we we want to publish it as soon as possible. But I also need to tell you that it doesn't work in every case, because sometimes every white opacity I have, should I infiltrate? You need to understand the indications. For example, in this case here, also a case of a patient that the mom came and brought the patient to our dental clinic crying because the child didn't want to go to school because people were making jokes about his front teeth and the child didn't want to smile. And we did a transillumination here in this white opacity and saw that it blocks the light. So probably a large thickness of the enamel is hypomineralized here. This patient here, he had also the dental development defects in enamel development defects in the molars. So a typical case of molar incisor hypomineralization. I tried to make the HYCON process, etching and alcohol. You can see it doesn't change at all, probably because I have a lot of enamel until I get to the hypomineralized lesion, and it's very thick. So there's no way here I will need to wear a little bit of enamel if I want to answer to my patient's statical demand. There are no miracles, okay? So in this case, we removed a little bit of the enamel. Of course, after explaining the patient, explaining the parents of the patient that we could not go, I would say, micro-invasively, but it was a decision that we all took. But I can still get benefits of resin infiltration. Let me explain you why. I removed a little bit of the enamel. I'm still into enamel, but I still have affected enamel here. You can see the white enamel. So in this white enamel, we do the deep infiltration technique. Now, since I removed the superficial enamel, I'm in the middle of the hypomineralized lesion. I have access to it. And then I infiltrate that part. And from this very whitish enamel after infiltration, I have this kind of substrate. that I do not have that whitish enamel. And it's much easier than for me to layer my composites and achieve a very nice aesthetical result. So you can see here after the deep infiltration and papers showing that I could go even and do my composites without placing an adhesive. And here after I place my restorations, here immediately after the tooth a little bit dehydrated, and then when the patient comes a week later, we can check here, and we had a very nice result, very nice aesthetics in not a micro-invasively approach, but I would say in a minimally invasive approach that could answer patients and family aesthetic demand. Okay, so this is one interesting case to show a limitation. And why does it occur? Because in this smaller incisor hypermineralization, I have usually lots of enamel here that I need to remove to access the very thick hypermineralized lesion. And here sometimes I need to remove it and do the so-called deep infiltration so that I can better that substrate and do my composite restorations. We have some papers, very interesting ones, on how to identify where the lesion is through transillumination. I suggest you read this one from Dr. Omar One, and the same idea will come to other cases. For example, in this one, we have MIH, we have fluorosis, and what we did here. You can see the fluorosis here. You can see the MIH here. So fluorosis, I know that resin infiltration is very cool, is very nice. So I do resin infiltration and all those steps that you already know, and fluorosis is gone. But my patient is still not 100% happy because of those MIH lesions in which only resin infiltration, in this case, didn't work 100%. It got much better. In some cases, it worked 100%, but it's not every time. So we need to take care. So here, do we have a solution? Yes, I remove a little bit of enamel, and now it will be really hard for me in a very small thickness of composite to mask this whitish enamel. I need to increase my preparation. I don't want that. So I do deep infiltration. I have now a very homogeneous substrate, and then it's easy for me to place my composites and achieve a very nice result. No fluorosis anymore, and also no more signs of the MIH in the anterior teeth. Mixing techniques to achieve a better balance between invasivity of the treatment and static result. And while I give the word to Suzanne to ask something on resin infiltration, please feel free to get your phone into this QR code that will take you to this book just on case reports of ICON, of resin infiltration smooth surface. We had the honor to have 2 cases in this book, and it's fantastic. It's something that I read. See, don't let me lie to you a lot here in my own home when I want to study and understand about resin infiltration. Suzanne, please.
Yeah, thank you for explaining this. For those of you who want to know more about the resin infiltration and more detailed and treatment planning and MIH and everything, there is maybe you already attended this, but there's an ICANN convention in the beginning of autumn. I think it's October. So follow the DMG website and Instagram to find out. And there you have 3 presentations on consecutive days that go much more into details. Yeah, but one question I have for you, there is a question that we're going to have like every time we talk about bleaching and ICANN. And what about if you want to bleach after you already done a resin infiltration? This is probably the question that I've been asked the most in the last 5 years when I talk about ICANN or talk with someone.
Let me tell you something. This is a doubt that we always had. There are some in vitro studies that shows it works. It works bleaching after ICANN. If I would choose, I already told you, I would do like the people from Cologne did, our friends in Cologne did, first bleaching, then resin infiltration. But we have an ongoing study here in Brazil that unfortunately was halted because of the pandemic, in which we're doing a group bleaching and then icon, the other group icon and then bleaching. So we don't have the answers yet of this clinical study. But I was reading this week. There was a new paper that evaluated that. I can even show to you here. Let me place here in the other screen that I really recommend to you. Okay, let me do this here and show here for you that shows exactly this, that I can actually bleach after infiltrating, and it doesn't give you any problem. So it's something that you can do. Unfortunately, we don't have yet clinical studies on that, but feel free to bleach after icon. But if you have the option, I would, up to the information we have today, do first bleaching and then icon. But I think that both ways will work fine. Okay.
Yeah, there was, by the way, a very nice review from almost the same working group. So if you search for literature and clinical or investigations, then check out this review as well. It's a really good summary of all the clinical data that's available for caries infiltration. And unfortunately, as much as I would love to talk about resin infiltration for the moment, I think we continue with the next level of intervention and talk about additive adhesive restorations.
Yes, then we come for the composites, as I was telling you. I think that now that we everybody incorporated adhesive procedures in the daily practice, and adhesion really made a revolution in the way that we indicate restoration for our patients. Please always take in mind that you can add a little bit of composite without much preparation, especially in intact enamel of young patients, and in cases in which you would need a lot of preparation for placing a ceramic veneer or a crown or an indirect restoration. Think about additive adhesive restorations. We're going to talk about ceramic veneers next week. It's a very nice material, fantastic success rates. But for many patients, it's not the first indication to veneer 20 teeth and place restorations in mouths that might not need them. So this is something that we need to think about. So if you ask me which is the perfect material for restoring teeth, I will tell you it's enamel and dentin. And this is what we try to do when we have, for example, here a trauma and we are doing a fragment reattachment, adhesive fragment reattachment. But sometimes we can do it. Some placing composites, especially in young patients, is something that is very, very nice. Here, this restoration, very proud to show the results of a fifth semester dental student here at our dental school. Very nice result in a very minimally invasive approach. And I think that every time composites are showing a better result on the long term. Of course, you have a technique to place those composites, and it's important for us to think on that. Think additive. This is the message. Can I only add material, or do I really need to subtract two structures with the preparation? Sometimes it's needed. Sometimes there's no other way, but sometimes we can only add. This is one case also of a dentist. She was a dental student at the time. We have rubber dam isolation. That's very nice. I really love to work under rubber dam isolation with only additive restorations, solving the very little problem that she had on her smile. Here's some cases that are little bit more complicated, but also for questions of value, monetary values for those patients in our university, we didn't have the possibility to treat them with more expensive materials or techniques. So all those cases were solved with direct composite restorations based on a previous wax up. So all of them additive without any kind of tooth preparation. Every time is getting easier for us to use composites. I can tell you, some years ago, we would have composite systems with 30, 40 different shades. And today we see a very nice trend in many, many brands, DMG included, in simplifying the access to composite systems and simplifying those systems with less shades, giving us very nice possibilities. So I really like this system here of DMG ecosite elements that has only 5 pure shades. I would say almost like dentin shades, and 4 layer shades. Think about enamel shades, and you can combine them and achieve a very nice result in many cases. If you need to do some individualization, some customization of your layering, you can also use the highlights with incisal, some more opaque and whitish or brown pigments. So very nice having more simple systems that usually with 2 shades, with 2 layers, you can already achieve a very nice aesthetic result. So I think this is nice. And also think about simplifying, make less invasion of patients with worn teeth. This is one technique that we're using a lot here in Brazil. Maybe some many restorations would increase in vertical dimension of occlusion is hard to do directly. So we do usually indirectly without preparation or with very small preparations onto the models that are articulated in symmetric relation. And then we adhesively cement that into the patient's mouth, and we're having some very nice results, even results as fantastic as this one. This patient only had crown lengthening and indirect composite restoration cemented without any kind of preparations on his smile. And you can see a huge change here in this case that was headed by my dear friend, Dr. Rogério Ribeiro. Composite works for that. Okay, if you have any doubt, please read this paper here from the people from Nijmegen in the Netherlands with very nice result. It's also already a consensus that we need to do minimally invasive treatment in those cases of oral rehabilitation in this fantastic paper of the European consensus statement. And I think that now we are going every time toward more digital ways and easy ways of producing those restorations. And it's not going to be a surprise if in a very few years, all of us would be planning our cases, our complex cases in our own computers. And instead of layering the composites as we know or as we learn to do, we were going to print the restorations in a very accessible printing machine with a very nice 3D printing resin. And I know DMG has fantastic ones in Europe and in America and maybe in Asia. Unfortunately, not yet here in Brazil. But those printed restorations, I think they are a future and then can be performed in very thin thicknesses and complying with the minimal intervention dentistry philosophy that led our talk in this morning, afternoon, evening. So for all those possibilities that we talked in this morning, I hope I could share something interesting with you. Feel free to make any questions. And if I can invite you, please, let's see us again next Monday together with my dear friend, Professor Rafael Monte Alto. That's one of the professors, at least here in Brazil and in Latin America, and also he has a fantastic book in Spanish that has one of the best didactic materials on ceramic veneers. I'm really excited to have the opportunity to be together with him next Monday, same time, with you here in Interdentale. Thank you so much for your attention.
Thank you, Leandro. Obrigada. Yeah, there was I think we should have made 3 lectures out of it because there's still so much to tell about everything that we just discussed. But anyway, as I told, there will be some more icon coming in autumn. So let's focus on some questions that we receive. And I think we already answered half of it, but someone is asking, how long does it take to see results if you do home bleaching with 10% carbamide, 1 to 2 hours a day?
That's what I told you a little bit earlier. Probably you're gonna have some days for 4 or 5 weeks until you can see, but the patient needs to know that the changes are very slight, but it will get whiter. So the patient needs to have a little of patience. If your patient is not patient, if your patient wants to see something immediately to believe in your treatment, maybe you should think about the combined technique using one session of in office for first to do the jump start.
I like that phrase, the patient needs to have patience. I think that's something we all wish on a daily basis, honestly. There's a question, how about tear affecting the tooth color after bleaching? You talked about coffee and wine, and is there any particular data about tea?
During treatment, avoiding any kind of pigment doesn't seem to have much importance, because the pigments, they are very large molecules, including the pigments you have in tea. So during treatment, do not worry that much. After treatment, of course, if a patient drinks a lots of tea and coffee and wine, you have a tendency for the bleaching to last a little bit less longer. But it doesn't mean that you need to re-bleach in 6 months, 1 year, 2 years. It's usually papers that look, even smoking patients that have performed bleaching after 3 years, the color is quite stable, doesn't get that much darker. So do not worry that much with that. I know that if you tell people in India that they should not drink tea, it's also going to be a problem. Like here in Brazil, you tell me I should not have my coffee. So maybe I don't want to make my treatment something that burdens patients' daily habits. Okay.
And someone is asking if you recommend a toothpaste for sensitive teeth during the bleaching procedure.
There are some people that recommend like potassium nitrate toothpastes that the patient should use it before bleaching and during bleaching procedure. It's very debatable if we have clinical evidence of how important it is. I prefer controlling my sensitivity with less time per day and lower concentrations. But it might be something that you can do together. Might be something that you can do together, as I explained about the subtle importance that potassium nitrate desensitizer have on this process.
And there's a question regarding MIH. If you use any a particular acid on the tools with when the enamel is gone. And just one other comment: if you're interested in MIH, there's also like a lecture or a talk on MIH on this in this program next week. So if you want to learn more about MIH, next week you have the chance from a very probably pioneer in research in MIH, Professor Bekes. Okay, but which acid do you use?
Yeah, if I use that deep infiltration technique, and if I remove the superficial enamel and expose the MIH, I just perform the normal icon protocol. So I use the icon etch, the hydrochloric acid, with the time, just observing the manufacture time, and then I perform the infiltration of a deeper enamel, light cure very well, and then I perform my restoration with composites. And then, since I'm already seeing the questions here, I already will join the next answer. If I apply icon infiltration and then I light cure and then I need to add composites, can I once again etch with phosphoric acid and place an adhesive and light cure and then come with my composites? Yes, I can. But there are some studies that have shown that my composite resin can copolymerize with the icon infiltrate surface, of course, if you don't have any kind of contamination. So sometimes if I just infiltrated this enamel and I need to add a little bit of composite, I just place the composite and light cure, and the resin infiltration will almost work like the adhesive on enamel. But if you contaminate that surface, you need to perform once again your adhesive procedure as standard.
Thank you. And there's a question, it's also like a very common question. How long between tooth whitening and icon treatment? So from a manufacturer's side, we recommend a washout phase of minimum 2 weeks. What do you recommend?
That's perfect, because we know that after bleaching procedures, we do not have the same bonding results. We learned that with dental adhesives. So the same idea goes for icons. Since maybe my whitening procedure has altered a little bit that enamel, I should wait a little bit. I would say 14 days, 2 weeks as a standard.
Then there is a question, which resin infiltration do you use? That's a quick answer. There's only one product available. So he's using Icon, the kit for resin infiltration. That was fast. Thanks for this question. Does Icon have a selection of shades for infiltration, or does it come in only one shade?
The mechanism of our icon, as I showed you, is only filling that spaces with resin with a more similar refractive index. So it's just one shade. You don't need to. It's almost going to be, when you apply, is a little yellowish, very low viscosity resin infiltrant. When you light cure, the yellowish goes away because of the consumption of the camphor quinone, and then it's just a transparent resin, but it's what it needed. You don't need to worry about shade selection.
There's a question about icon treatment relapse. What are the possible factors which can cause the relapse and reoccurring of the white spot? Do you have any experience with this?
No, because if I do for a white relapse, I'll need a new lesion probably if I really infiltrated well the first one. What you could fear is like some staining of the composite, as it happens with composite. But we have like 7-year, 8-year cases, and we didn't see that. And if you do, what would you do with a normal composite? You just repolish, and then you have a new surface anymore. Once again.
Another question is the deep etching or the deep infiltration protocol harmful for the pulp? What is your answer?
We're not placing that on dentin. We're placing that on enamel. If I remove all the enamel, then there's no indication at all for infiltration. Infiltration is for enamel, okay? No, not on dentin. So I still have the enamel as a barrier. I have all the dentin as a barrier. And some studies have shown, yes, acid can do some damage, but you have a very thick way to reach the pulp, and those damages are lower than the damage that even on hydrogen peroxide that you use in bleaching for millions and millions and millions of patients produces. So I think that clinically is not something that we worry. I'm using Icon for 11, 12 years now, and I have never had a case of post-op sensitivity even. Imagine for a bigger problem. That's what I can tell you from my experience and discussions that we already had on this topic.
Okay, and we have two last questions. And the second last is, when do you etch? Do you concentrate more on the whiter positions, or do you etch all surface?
If I have a demarcated white lesion, just in one region, I just etch there. If I have like a diffuse opacity, like in fluorosis cases, usually the whole tooth, then I apply in the whole area. Okay, if you just one region here, then apply just there.
And how long after removing brackets do you recommend bleaching? And for how long you have to wait with the Icon?
if you remove the brackets and you see the white spot lesions and you want to infiltrate, maybe as soon as possible, because after you remove the brackets, hygiene gets better and uses fluoride, and then you have you usually will thicken the surface layer. So when you use just after removing the brackets, maybe, we don't have studies on that, but this is as a hypothesis, you're gonna have easier access to the subsurface lesions. So I wouldn't wait that much, even though the patient will want to wait because he is already after a long orthodontic treatment, he doesn't want to sit in the dental chair for a while. It happens sometimes.
Yeah. So I think we are done with the questions, and I would like to also ask Julia to be with us. And yeah, first of all, Leandro, thank you so much for taking us to this